Hello, hi. Assalamualaikum and good morning all of you. I hope you guys are doing great. I am Dr. Yang. So today's lecture topic will be on removable appliances. The topic will be based on your textbook here. So make sure you read this textbook and then based on my notes as well so that you have better understanding of this topic. Okay, this is the learning outcome of this topic. At the end of this lecture, you should be able to explain the components of removable appliances and their uses, and you should be able to construct and manipulate removable appliances. This is the content of our lecture for today. I will explain one by one about the definition of the removable appliances, and I will also explain how do it work and then the action of the removable appliances. I will also explain the components of the removable appliances. There are three basic components, which is the retentive components, the active components, and the base plate. And then I will also explain about the clinical management of the removable appliances, and then also problem encountered in removable appliances therapy. And also I will have some pictures to show about basic design of removable appliances. As for introduction, removable appliances are devices that can be inserted into and removed from the oral cavity by the patient at will. It was used since 19th century in the US and in the European country. Removable appliances can be effectively used to treat a number of minor malocclusion. So what is the difference between removable appliances and myofunctional appliances? So in this topic, we will limit our discussion for removable appliances. So removable appliances, the difference between removable appliances and functional appliances is removable appliances is a mechanical device that moves the teeth from the force from the wire. However, the myofunctional appliances are the appliances that make use of muscle force to make changes in the malocclusion. Removable appliances offer a number of advantages, including the ability to maintain oral hygiene and less chairside time. These are the advantages of removable appliances in your textbook. Removable appliances can be removed from the mouth and then put it back again. So that's why it's easier for patient to maintain a good oral hygiene. This is because patient can remove the appliance and then brush their teeth properly and then put back the appliance inside the mouth. And then in addition, the appliance can be kept clean by the patient. Second advantages is most malocclusion require tipping type of tooth movement, which can be readily carried out using removable appliances. And then beside tipping, overbite reduction can be undertaken by intrusion and extrusion of the teeth. Removable appliances are fabricated in the lab utilizing less chairside time of the orthodontist. And then these appliances take less chairside time, therefore the orthodontist can handle more number of patients. Removable appliances bring about tipping tooth movement, thus lesser force are used than those needed for the bodily tooth movement. As force employed are less, the strain on the anchor teeth is lesser than in the fixed appliances therapy. The removable appliances can be used by general dental practitioners who have received adequate training. This makes it possible for a specialist to concentrate on more difficult cases, usually using fixed appliances. And then the fabrication of removable appliances need less inventory. They are relatively less expensive than the fixed appliances. Removable appliances take less chairside time, therefore are by far less expensive, and they also can be used in community-based program wherein a large number of patients are treated. Removable appliances are less conspicuous than the multi-banded fixed appliances, and then it's less complicated. And then damaged appliances that apply undesirable forces can be removed by patient, therefore less trauma to the soft tissue. Their main disadvantage is the need for patient cooperation. Failure to adhere to prescribed removable appliances where scheduled will result in slow treatment response, or no changes at all. So patient cooperation in wearing the appliance is very important for the success of removable appliances therapy. These are the list of disadvantages of removable appliances as in your textbook. As the appliances can be removed, patient cooperation is vitally important for the success of the treatment. If patient does not wear the appliances and then they just remove the appliances when their parents is not around, and then we cannot move the teeth, and then the treatment will be failed. Okay, and then second disadvantages is only capable of tipping tooth movement. This is major limitation of removable appliances. So it cannot do bodily movement, it cannot do rotation, and it cannot talking the teeth. So they only allow minor tooth movement. Okay. And then the third disadvantages is whenever multiple tooth movement are to be carried out, it should be done one at a time. Thus, the treatment duration is prolonged in case of severe malocclusion. This is because usually we move the teeth using the active component. And then to retain the appliance in the mouth is using the retentive component. The more active component, the lesser the retention of the removable appliances. So that's why any tooth movement should be done one at a time. So patient will have multiple sets of removable appliances, which will increase the prolonged treatment time. Okay, and then the following disadvantages is multiple rotation are difficult to treat using removable appliances. Usually in multiple tooth movement or rotation, we use fixed appliances. In cases requiring extraction, it's very difficult to close the residual space by forward movement of the posterior teeth because the tip will tip forward, and then the arrangement of teeth will not be good. Okay, then as the appliances are removable, there are greater chance of patient misplace and damaging them. Okay, patients should exhibit enough skill to remove and replace the appliances without distorting them. Okay, they cannot be used to treat severe class 2 or class 3 malocclusion with unfavorable growth pattern. Removable appliances work by applying a single force on the crown of the teeth. Thus, removable appliances act by tipping the tooth around its center of resistance. So how does removable appliances move the teeth? It will move the teeth in a tipping movement. The tipping movement can be in mesiodistal or buccolingual direction. The key point to be considered is the position of the root apex before the beginning of the treatment. So how do we know the position of the root apex? So this is when the radiograph or OPG is important, because we want to assess the position of the root apex before we prescribe any treatment. Okay, so the teeth that have the apex at the correct position are ideally suited for treatment with removable appliances. Okay, now let's focus on the root apex of this canine. So let's focus on the above photo first. Okay, the position of the root apex of the canine is at the correct position, where the root apex is at the position where it should be. So what the removable appliances do, so the wire will tip the teeth distally so that the crown of the canine goes into the good position in the arch. So this is before we activate the component, the active component. And then this is after few months of treatment, we can see the crown of canine tip into the correct position. Okay, so tipping movement is very efficient movement in the treatment of the removable appliances. So the roots at the position of the roots apex is very important. So let's say focus on the below photo. Let's say the position of the roots apex is not ideal, is away from its correct position. So when you tip, the crown will not move into the correct position. So this is wrong. This is why radiograph taking is very important prior treatment in orthodontics. What is the position of the root apex? Is not ideally positioned for the removal appliances. So patient may be suitable for fixed appliance therapy rather removal appliances therapy. So in what cases? if the teeth need bodily translation, derotation or uprighting, therefore they may need a fixed appliance rather than removable appliances. Why? Because this movement require double force on the crown of the tooth, not a single force as we seen in the tipping movement. So let us see the photo. So we can see that the premolar is rotated, so it might need two force. One is pulling to the mesial and one force is pulling to the distal to derotate. So for removable appliances, they cannot react like this. So that's why in this case, fixed appliances is more suitable for treatment. How about other tooth movement? Removable appliances can allow selective intrusion and extrusion of teeth by addition of bite planes. Bite planes can be anterior bite planes or posterior bite planes. What is bite planes? Bite plane is a modification of the acrylic base plate. What is acrylic base plate? Acrylic base plate is one of the components of the removable appliances. Okay, these are the components of removable appliances. We have three basic components of the removable appliances, which is the active components, retentive components, and acrylic base plate. Okay, in some other books, they will be given acronym of ARAB, A-R-A-B. A stands for active components, R stands for retentive, A is anchorage, and then B is base plate. Actually, anchorage and base plate is quite similar. So for our textbook as biology, they combine into three for better understanding. So you just need to know the three components of removable appliances, which is the active, retentive, and base plate. So after this, I will explain one by one. Okay. What are the retentive components? The retentive components are the components that help in keeping the appliance in place and resist displacement. The better the retention, the better the removable appliances. Wire components that aid in retention of removable appliances in patient mouths are called clubs. So I think by this time you already did your wire bending exercise. So usually the clubs, the most commonly used clubs is the Adams clubs. So the better the retention, the better the removable appliances. So to keep the appliance in place, usually we will put two Adams clubs on both molars, and then for the anterior we may put Adams clubs on the premolar as well, or south end clubs or on the incisor. Okay. How do clubs work? The clubs act by engaging certain constricted area of the teeth that are called undercuts. When clubs are fabricated, the wire is made to engage this undercut so that their displacement is prevented. There are two types of undercuts that are found in natural dentition. The first one is the buccal or lingual cervical undercuts, and then the second one is the mesial and distal proximal undercuts. So when you look at the figure 1, A is the cervical undercuts, whereas B and C are mesial and distal proximal undercuts. What is buccal and lingual cervical undercuts? The buccal and lingual surface of the molar have a distinct undercut at the cervical margin. These undercuts are available only in those teeth that are fully erupted. For example, the clubs can engage these undercuts are circumferential clubs and Jetson clubs. And then for the mesial and distal proximal undercuts, offers more retention than the buccal and lingual undercuts. They can be seen when the molar is viewed from the buccal aspect. These proximal undercuts are more pronounced than the cervical undercuts and therefore offer better retention. Example of clubs that can engage this undercut are Adams clubs and Crozat clubs. What is the requirements of an ideal clubs? The ideal clubs should offer adequate retention even in the presence of shallow undercut. It should be passive and do not apply any active force to the teeth that will bring undesirable tooth movement. It should not impinge on the soft tissue and should not cause tissue ulceration. It should permit usage in both fully erupted as well as partially erupted teeth. It should be easy to fabricate and it should not interfere with normal occlusion. Okay, in this lecture, we will be discussing a few types of clasps, which is the circumferential clasps, the Jackson clasps, the Adams clasps, the south end clasps, the triangular clasps, the ball end clasps, swatch clasps, and crozet clasps. Okay, the first one is the circumferential clasps. It's also known as three-quarter clasps or C clasps because of the shape. It engaged to buccocervical undercut as shown in this photo, and then the wire travels from one proximal undercut along the cervical margin, then carried over the occlusal embrasure to end as a single retentive arm on the lingual aspect that gets embedded in the acrylic base plate. Okay, and then the advantages is simple design and easy to fabricate. But the disadvantages is it cannot be used in the partially erupted teeth because the wire needs to travel at the undercut, and then in the partially erupted teeth, if you do circumferential clasps, it will cause soft tissue trauma because the wire will travel subgingivally. So in cases with partially erupted teeth, do not design these clasps as a retentive component. The next one is Jackson clasps, or also known as full clasps or U clasps. Okay, it's called U clasps because the shape is U, and then it is full because it covering all the undercuts. Okay, and then it engaged to buccocervical and mesodistal undercuts, and then the wire travels from buccocervical margin and both proximal undercut, then carried over both the occlusal embrasure to end as a retentive arm on the both sides of the molar. Okay, make sure the wire that travels at the occlusal embrasure do not interfere the occlusion. Okay, and then the advantages, it's simple to construct and it has adequate retention. However, the disadvantages is the same as a circumferential clasp where it cannot be used in partially erupted teeth. The next one is the Adams clasps. It's also known as Adams crisps, Liverpool clasps, universal clasps, and modified arrowhead clasps. This is the most commonly used clasps in the construction of removable appliances because it offers a lot of advantages. Now let's see how do the Adams clasps work. It works by engaging to the mesodistal undercuts. There are three parts of Adams clasps, which is two arrowhead that engage to the undercuts, and then these two arrowhead are connected with bridge. Okay, and then there is also two retentive arms that travels along the occlusal embrasure to the acrylic base plate on the palatal or lingual side. Okay, and then the arrowhead are connected to each other by a bridge that is 45 degrees to the long axis of the tooth. What are the advantages of Adams clasps? It is rigid and offers excellent retention. It can be fabricated on deciduous teeth as well as permanent teeth. They can be used on both partially or fully erupted teeth with minimal soft tissue trauma. It can be used on molars, premolars, and on incisor. We can use Young's universal pliers to fabricate the Adams clasps, and then it is small and occupies minimum space, and the clasps can be modified in a number of ways. There are 7 ways to modify the Adams clasps. The first one is Adams with a single arrowhead. It is indicated in the partially erupted teeth, and the arrowhead is engaged to the mesial undercut of the last erupted molar, and the bridge is modified to encircle the tooth distally and end at the palatal surface as a retentive arm. Usually, the Adams with a single arrowhead are used in the last erupted molar because on the distal part of the last erupted molar, usually there is a lot of soft tissue covering. So to minimize the soft tissue trauma, the arrowhead is made on the mesial part only. And then the second modification is the Adams with J-hook. J-hook is soldered on the bridge of the Adams clasp, and then this hook can be used to engage elastic. And then the third modification is the Adams with incorporated helix. A helix can be incorporated into the bridge of the Adams clasp. So we will fabricate the Adams clasp normally by adding the helix, a loop on the bridge. It's quite tough to bend helix on the bridge of the Adams clasp. And then the function of the helix is the same as J-hook, which is to help in engaging elastic. So in what cases do we use elastic together with the removal appliances? So in the cases where we combine the treatment of fixed appliance on one arch and removable appliances in one arch, then only we can use the elastic in certain cases only. The fourth modification is Adams with additional arrowhead. The additional arrowhead engages the proximal undercut of the adjacent tooth and is soldered to the bridge of the Adams. It offers additional retention. Okay, when you look at this photo, and then there is a additional arrowhead engaged at the proximal tooth, usually the mesial tooth. Okay, and then is soldered to the bridge of the Adams. Okay, and then the fifth modification is Adams with soldered buccal tubes. Okay, the buccal tube can be soldered on the bridge of the Adams clasp here. Okay, and then it permits use of extraoral anchorage using face bow headgear assembly. So usually we use the buccal tubes as a connection to the face bow that connects the headgear. Okay, let's see the next slide. There is some photos that is related to this kind of modification. Okay, now let's focus on the Adams clasp on the premolar. Okay, there is a buccal tube that's soldered at the bridge of the Adams and on the both sides. So face bow is then attached to the buccal tube, and then there is a two part of the face bow, the inner part that connects to the buccal tooth on the bridge of the Adams, and then the outer part of the face bow that engage to the headgear. I think you know the headgear. I've already explained about the headgear in the orthopedic appliances lecture. Okay, so you can relate this topic regarding the modification of the Adams clasp with the face bow and the headgear. The next modification is the Adams with distal extension, as what you see in this photo. The distal arrowhead has a small extension incorporated distally, and then the function of this distal extension is the same as the helix on the bridge, and the J-hook is to engage the elastic. Usually in this case, one arch will be removable appliances, usually on the upper arch, and then the lower arch will be fixed appliances. Okay, we won't put elastic on both removable appliances on lower arch and upper arch because it will affect the retention. Therefore, in cases that use elastic, is either one arch is removable appliances and the other arch is fixed appliance, or both arch is fixed appliances. Okay, and then the final modification is the Adams on incisor and premolar. The Adams clasp can be fabricated on the incisor and premolar when retention in those areas is required. It can be constructed to span a single tooth or the two teeth. For example, the Adams clasp on the incisor. Usually for the central incisor, we put Adams clasp on both like this. Okay, I've never seen Adams clasp on a single central incisor teeth because the undercut is very minimal, and then there is a higher risk of soft tissue trauma. So for Adams clasp on the incisor, usually we put on both central incisor like this, and then for the premolar, we put on the single tooth of premolar as what you seen on the previous slide. Okay, this is south end clasp. It is used in the anterior region, specifically the incisor. It engages along the cervical margin of both central incisor. The distal end are carried over the occlusal embrasure to end as a retentive arm on the palatal side. The next one is triangular clasps. It is called triangular because of the shape, and this is very difficult to fabricate and very rarely used clinically. It engages the proximal undercut between two adjacent posterior teeth, okay? And it is indicated when additional retention is needed. Okay, this is a quite commonly used clasp, which is ball end clasp or ball-ended clasp. It can be soldered or preformed wire having a ball at one end. Okay, it engages the proximal undercut between two adjacent posterior teeth. It can be between posterior teeth or between the incisor teeth. So it can be used all over the proximal space on all over the teeth. Okay, the distal end are carried over the occlusal embrasure to end as retentive arm on the palatal side. Is indicated when additional retention is required. Okay, this is a clinical photo of a preformed ball-ended clasp. We can see the supplier will sell it like this. So you can buy from supplier. They already have the ball at the end of the wire, so that is why that it is called ball-ended clasp. And then this clasp they hook at the proximal area of the incisor. And then the next photo is the twin block functional appliances, where they use the ball-ended clasp on the lower incisor to gain retention of the lower part of the twin block. And then you also can see the Adams clasp on the lower premolar, and then the Adams clasp on the upper premolar and the upper molar. Okay, this is Swatch clasp. It's also known as arrowhead clasp, and then this was first invented before the Adams clasp, and then they modify this arrowhead clasp, and then only they create the Adams clasp. So personally, honestly, I haven't seen this clasp clinically. So this is a very historic design. So how do it work? It engages the interproximal undercuts between the molars and between premolars and molars. And then it is not routinely used nowadays. Why? Of course, it's very difficult to construct and very time consuming. It needs a special forming pliers to fabricate, and then it occupies large amount of space in the buccal vestibule, and then therefore there is a high chances of soft tissue trauma and ulceration of the gingival tissue over here. Okay, so patient will feel very uncomfortable and very painful because of the ulcer while wearing the clasp. The final type of clasp is crozet clasp. It resembles a Jetson clasp but has an additional wires here. Okay, the additional wires engage into the mesial and distal proximal undercuts. Thus, it offers a better retention than the Jetson clasp. So remember, Jetson clasp is also known as U clasp because of the shape, and also full clasp because it covers all the proximal area and undercut area. Okay. Okay, now we already finished off with the retentive component, and now we will move into next component, which is the active component. Remember, we have three basic components of the removal appliances, which is the retentive components, active component, and the acrylic base plate. Okay, now the active components, we have four types of active components, which is both spring, screws, and elastic. Both are mostly used for incisor retraction. Spring will allow various tooth movement, which is the tipping movement, and then screws usually for arch expansion, moving group of teeth either in buccolingual or mesodistal direction, and finally the elastic is used in conjunction with the fixed appliances. Bows are active components that are mostly used for incisor retraction. There are many types of bows, which is short labial bow, long labial bow, split labial bow, reverse labial bow, Roberts retractor, Mills retractor, high labial bow with apron spring, and fitted labial bow. Short labial bow is made from 0.7 mm round stainless steel wire. It is a bow that makes contact with the most prominent labial teeth and the two U-loops that ends as a retentive arm distal to the canine, and then it will extend to the palatal and then to attach to the acrylic base plate. This bow is stiff and exhibit low flexibility. Is indicated only in cases with minor overjet reduction and anterior space closure. It is suitable as a retaining device post-debond. Okay. Activation is by compressing the U-loops so that the labial bow is displaced palatally by 1 mm. Long labial bow is also made up by 0.7 mm round stainless steel wire, similar to short labial bow except that it extends from one first premolar to the opposite first premolar, and then the distal arm of the U-loop are adapted over the occlusal embrasure between the two premolars to get abandoned in the acrylic base plate. So when you bending the wire, make sure the wire is adapted over the occlusal embrasure properly, so that when we make the appliance, when patient bite, the wire will not interfere the patient occlusion. Okay, the indication for the long labial bow is minor anterior space closure, minor overjet reduction, closure of space distal to canine, guidance of canine during canine retraction using palatal retractor, and as a retaining device after debond. Activation of the long labial bow is similar to that described for short labial bow, is by compressing the U-loop about 1 mm. The modified form of the long labial bow can be made by soldering the distal arm of the U-loops to the bridge of the Adams clasp. The next one is split labial bow. It is made from 0.7 mm round stainless steel wire. A labial bow is split in the middle. This results in two separate buccal arms having a U-loop each, and this exhibit increased flexibility compared to the short labial bow. Indication is for anterior retraction, closure of midline diastema by adding hooks on the distal surface of the opposite central incisor, and then this two split labial bow is overlapping in the cases with midline diastema. Activation is by compressing the U-loops 1 to 2 mm at a time. This is reverse labial bow. It is made from 0.7 mm round stainless steel wire. It's also called a reverse loop labial bow. The U-loop are placed distal to the canine, and free ends of the U-loops are adapted occlusal between the first premolar and the canine. As there is a long span of wire is cooperated, the bow exhibit increased flexibility. It is indicated in the cases with minor anterior retraction and minor overjet retraction, and also as a retaining device. The main difference in the reverse labial bow and the other labial bow is the design of the U-loop. So therefore, the activation also different from the reverse labial bow and the other labial bow. For the other labial bow, which is short labial bow, long labial bow, and split labial bow, the activation of the U-loop is by closing of the U-loop, meaning that the plier will compress the U-loop about 1 mm so that the labial bow will be moved palatally around 1 mm. But for the reverse labial bow, the activation is done differently from the other labial bow. So the first step is by opening of the U-loop, and then this will result in the lowering of the labial bow in the incisor region. And then step 2 is the making of compensatory band at the base of the U-loop to maintain the proper level of the bow. This is Robert's retractor. It is made with 0.5 mm stainless steel wire having a coil of 3 mm diameter, mesial to canine. The usage of thin wire with increased the wire length by adding the coil makes the label bow become highly flexible and therefore less stable. Adding the stainless steel tube of 0.5 mm internal diameter at the distal arm of the retractor may increase the stability of the wire. The indication is for severe anterior proclination with overjet more than 4 mm. Robot retractor is highly flexible, therefore it can deliver lighter force suitable in adult. So the keyword for robot retractor is adding a coil will increase the wire length, therefore make it highly flexible. So when it is highly flexible, it will deliver lighter force and that it can be used in a severe anterior proclination with overjet of more than 4 mm. This slide shows the robot retractor on the study model and intraorally. And then we can see that there is a metal tubing or stainless steel tubing at the distal arm of the robot retractor to increase the stability of the highly flexible retractor. And then on the second photo, we can see there is a wax placed on the gingival area, and then this wax is used as a relief so that when we make the robot retractor, it's positioned away from the soft tissue. And that is, we also can see there is a Adams clasp as a retentive component of these appliances. And then clinical photos here shows that the robot retractor is placed away from the soft tissue so that it won't cause any ulceration. This is male's retractor, and then it is made up from 0.7 mm round stainless steel wire. This is a level bow having extensive looping of the wire in order to increase the flexibility and the range of action. What is the range of action? The range of action is the ability to remain active over extended period of time. So because it can remain active over extended period of time, so it is indicated in the patient with large overjet, which is more than 4 mm. So it is also called extended label bow. The disadvantages is very difficult to construct because there is extensive looping, and then there is also poor patient acceptance because the wire might cause soft tissue irritation and ulceration to the patient. This is a high label bow with apron spring. It uses 0.9 mm round stainless steel wire, a heavy wire label bow that extends up into the labial vestibule. And then there is an apron spring made up from 0.5 mm wire that is attached to the high label bow, and then the apron spring is used for retraction of one or more teeth. This high label bow with apron spring is highly flexible and used in cases with large overjet. Activation is by bending the apron spring towards the teeth up to 3 mm at a time. But the disadvantages are it may cause soft tissue injury and ulceration to the soft tissue, and then difficult to construct. This is fitted label bow. It is made up from 0.7 mm round stainless steel wire. The wire is adapted to conform to the contours of the labial surface of the anterior teeth, and then the U-loop is usually small. It's used as a retention device after completion of fixed orthodontic therapy, and it cannot be used for tooth movement. So for the fitted label bow, usually we added the Adams clasp as the retentive components, and then this appliance with the fitted label bow will be used as a retainer. This is a clinical photo of the fitted label bow. We can see that the wire is adapted to the contours of the labial surface of the incisor, and then the U-loops is really small. It does not extend to the gingiva at all. Okay, now we will move on to spring. Spring is another active component that are used for various tooth movement. In this lecture, I will talk about finger spring, cranked single cantilever spring, Z spring, coffin spring, canine retractor, U-loop canine retractor, helical canine retractor, and palatal canine retractor. There are three basic classification of spring. The first one is based on the presence of or absence of helix. They can be classified as simple, which is without helix, and compound, which is with helix. So, for example, this is a type of compound springs where there is a presence of helix or coil, okay? And then the second classification is based on the presence of loops or helix. They can be classified as helical spring having a helix. So this is a helical spring. And then loop spring have a loop. So this is a loop, so it's called loop spring. And then the third classification is based on the nature of stability of the spring. They can be classified as self-supported spring or supported spring. Okay, for self-supported spring, they are usually made of thicker gauge wire, for example, 0.7 mm stainless steel wire. Thus, they can support themselves. So, second one is supported spring. They are made of thinner gauge wire and thus lack adequate stability. So, usually the wire is 0.5 mm stainless steel. Hence, the section of the spring is encased in a metallic tubing to give it adequate support. So, in this photo, it shows the supported spring where there is a metal tubing to support the thinner wire. Okay. What is the ideal characteristic of a spring? First, it should be simple to fabricate. It should be easily adjustable. It should apply force efficiently. It should not slip or dislodge over a sloping tooth surface. It should be fit without discomfort. It should be easy to clean, and that it should be robust and should remain active over a long period of time. This is the factors to be considered in designing a spring. Okay, you need to fully understand this equation because this equation will be used frequently in orthodontics. And then usually the question about this topic will be asked in MCQs. Okay, there are 5 factors to be considered in designing a spring. Okay, the first one is the diameter of wire. The second one is the length of wire. The third one is force to be applied. The fourth one is patient comfort. And the final one is direction of tooth movement. Okay, have a look on this equation. So what you need to understand is that force is directly proportionate with the diameter of wire, but inversely proportionate with the length of wire. So now let us focus to the diameter of wire. Okay, based on the equation, the thicker the wire, the higher the force, but the lower the flexibility. By doubling the diameter, the force will increase by 16 times. Thus, decreasing the diameter, the lighter force is applied and therefore the wire remains more flexible and active over a longer period of time. So, let's have a recall on the robot retractor. Robot retractor have a coil, and having a coil will increase the wire length. So because we increase the wire length, the wire become more flexible, and then also the diameter of the wire is only 0.5 mm. So it will deliver a lighter force, and then the wire will remain active over a longer period of time. Okay, and then the next factor is the length of wire. The longer the wire, the lighter the force, the longer the flexibility, and the spring may remain active for a long duration of time. By doubling the length, the force can be reduced by 8 times. How to increase the wire length is by incorporating helices and loops. So just recall back for the robot retractor. As what I said before, by incorporating the helix, it will increase the wire length, and that the wire diameter is 0.5 mm, which is thinner, and then therefore it will increase in flexibility and will deliver lighter force, and can remain active over a longer period of time. And then the third factor is force to be applied. An average force of 20 gram per centimeter square is recommended for most tooth movement. It can be measured using a special scale. I'm not sure whether this scale is present in your clinic or not. Later, I will show you the examples of the scale. And then the force is based on the number of teeth to be moved, root surface area, and the patient comfort. Okay, now we will move into the next factor in the next slide. Okay, the fourth factor is the patient comfort. The spring should not cause any patient discomfort by way of its design, size, or the force it generates. The patient should be able to insert the appliance with the spring in the proper position so that desired tooth movement can be achieved. So patient education is very important during issue of appliance. As a clinician, we need to teach the patient how to insert the appliance and how to remove the appliance properly without distorting the wire. Okay, and then the final factors is the direction of tooth movement. Direction of tooth movement is determined by point of contact between the spring and the tooth. Palatally placed springs are used for labial and mesial distal tooth movement, while buccally placed springs are used when the tooth to be moved palatally and in mesial-distal direction. So in order to understand this, what you need to understand is that by using spring, the spring will deliver pushing movement. So if you want to push the teeth labially, place the wire at the palatal. If you want to move the teeth palatally, then place the wire buccally. Okay, remember pushing movement. Finger spring is made out by 0.5 or 0.6 mm round stainless steel wire. It's also called a single cantilever spring, as one end is fixed in acrylic and the other one is free. Indication is for mesial distal movement of the teeth, and teeth should be within the line of arch and not rotated. It consists of an active arm of 12 to 15 mm length, a helix of 3 mm internal diameter, and a retentive arm of 4 to 5 mm length that is kept away from the tissue and ends in a small retentive tag and abandoned in the acrylic base plate. How to construct a finger spring? The coil should lie along the long axis of the tooth to be moved. A helix of 3 mm internal diameter and a retentive arm of 4 to 5 mm length that is kept away from the tissue and ends in the small retentive tag. The direction of coil should be opposite to that of intended tooth movement. Okay, for in this photo, it shows that we want to move the teeth mesially. So the direction of the coil, okay, should face the opposite side. Okay. Prior to acrylicization, the helix and the active arm are boxed in wax so that the spring lies in recess between the mucosa and the base plate. Meaning that before you put the acrylic, you need to put a wax here so that the acrylic will not spread inside the wire, okay, and then the coil, so that it's easier for you to do the activation later, okay. And then how to activate it? So activation is by moving the active arm up 3 mm towards the teeth intended to be moved. For example, in this photo, it shows that we want to move the lateral to the mesial. So we put the plier here, okay, the universal plier, and then you bend the wire around 3 mm. Another way to activate is to put the plier here, and then you open the coil so that it will pushes the teeth around 3 mm mesially. This is cranked single cantilever spring. It is made from 0.5 mm round stainless steel wire. Its indication is to move the teeth labially. It consists of a coil close to its emergence from the base plate, and then the coil helps in increasing the flexibility of the wire by increasing the length of the wire. Activation is by unwinding the coil or open up the coil. Z-spring is made up from 0.5 mm round stainless steel wire. It's also known as double cantilever spring because they have a double coil here or helix here. Indication is for the labial movement of incisors and minor derotation of incisor. It can be used for 1 or 2 incisors. It consists of 2 coils of very small internal diameter, a retentive arm of 10 to 12 mm length that get embedded in the acrylic. The spring should be perpendicular to the palatal surface of the tooth and also should be boxed in wax prior to acrylization in order to prevent the acrylic to flow inside the coil. Activation is by unwinding the coil or by opening both of the helices around 2 to 3 mm at a time. For derotation, only one helix is open. Depends on which direction do you want to derotate the teeth. This spring is made up from 0.5 mm round stainless steel wire and it is used for buccal movement of premolars. It consists of a T-shaped arm whose ends are embedded in acrylic and the loops are incorporated in both arms to increase the flexibility of the wire. The activation is by pulling the free end of the T towards the intended tooth movement. Okay, just put the plier here and then pull towards the intended tooth movement, pull it buccally. This is coffin spring. It uses 1.2 mm round stainless steel wire. It is used for slow maxillary expansion in cases with constricted upper arch and a unilateral crossbite. It consists of U-shaped or omega-shaped wire placed in the mid-palatal region with the retentive arm incorporated into the base plate. And then it gain retention from the Adams clasp. And then this appliance with the coffin spring at the mid-palatal and Adams clasp at the premolars and molars are called en masse appliance. The buccal tubes can be soldered at the bridge of the Adams clasp so that this appliance can be connected to the orthopedic appliances, headgear, through the face bow. Usually the buccal tube is being incorporated at the bridge of the Adams clasp of premolar. And then the activation is by pulling the both sides of the base plate of the acrylic apart by 1 or 2 mm to allow slow maxillary expansion. Okay, this photo show how en masse appliance being connected to the headgear via face bow, and then this whisker looking appliance is called face bow. They have inner bow and the outer bow. The inner bow is connected to the en masse appliance through the buccal tubes that being soldered at the bridge of the Adams clasp on the premolar, and then the outer bow is being connected to the headgear. Okay, so the buccal tubes are soldered to the bridge of Adams clasp so that this appliance can be connected to the headgear through face bow. It is used in cases with class 2 malocclusion with constricted upper arch. Canine retractors are one type of the spring used to tip canines in the distal direction. Okay, remember, removable appliances are best used to tip the teeth. So in order to get a controlled tipping movement, the position of the root apex should be in the correct position. Okay, it should be positioned like in the above photo. It shows that the root apex is at the correct position. So the spring will tip the canine crown distally so that it will arrange properly like this. Okay, and below photo, the below ones, it shows that the position of the root apex is positioned wrongly. So when you tip, and then the tooth will not be positioned correctly. Okay. There are 3 ways to classify the canine retractors. The first one is based on their location, either buccally placed or palatally placed, and then it's based on the presence of helix or loop, whether with helix or with loop, and then based on the action, their mode of action, whether push type or pull type. Okay, in this lecture, I will explain four types of commonly used canine retractor, which is U-loop canine retractor, helical canine retractor, buccal canine retractor, and palatal canine retractor. U-loop canine retractor uses 0.6 or 0.7 mm round stainless steel wire. It consists of an active mesial arm, okay, this part is mesial, and then the U-loop and a distal retentive arm that are banded in the base plate. The base of the U-loop should be 2 or 3 mm below the cervical margin and away from gingiva to prevent soft tissue trauma. The end of the mesial arm is adapted around and below the canine mesial contact point near the gingiva. Indication is 1 to 2 mm canine retraction distally. Activation is by closing the loop by 2 mm or cutting the end of the active mesial arm and readapting it. Okay, the advantages is less bulky and ease in fabrication. Helical canine retractor uses 0.6 mm round stainless steel wire. It's also called reverse loop canine retractor and it consists of active mesial arm, a coil of 3 mm diameter and a retentive distal arm. The retentive arm is adapted between the premolars and the active arm is adapted and engage the canine below the height of contour. The height of the coil should be adjusted below the based on the vestibular height, and that it is used especially in the mandibular arch and in the shallow sulcus, and then the activation is by closing the loop by 2 mm or cutting the end of the active arm and readapting it. This is buccal canine retractor. It can be self-supported or supported. For self-supported, it uses 0.7 mm stainless steel round wire, and then if it supported, it will use 0.5 mm stainless steel with metal tubing. It is used for buccally placed canine and canine placed high in the vestibule, and then to move the canine in distal and palatal direction. Okay. And that it consists of an active mesial arm, okay, and then a coil of 3 mm diameter and the distal retentive arm that are banded in the acrylic base plate at the palatal part. And then the coil is placed distal to the long axis of the canine. Okay, how to activate this kind of retractor? So it depends on which wire that you use. If you use self-supported wire, which is 0.7 mm wire, is activated by closing the loop 1 mm at a time. And then for the supported wire, okay, you can close the loop up to 2 mm at a time. Okay, this slide shows the biggest difference between the two types of buccal canine retractor, which is the self-supported and the supported. So self-supported, it uses 0.7 mm stainless steel round wire, okay, and then for the supported, it uses thinner wire, which is 0.5 mm, and then there is a metal tubing at the distal retentive arm. Okay, this is palatal canine retractor. It made up from 0.6 mm round stainless steel wire. It consists of an active mesial arm, a coil of 3 mm diameter and a distal guide arm. An active arm is placed mesial to canine and the helix or the coil is placed along the long axis of the canine. Indication is for retraction of canine that are palatally placed, and activation is by opening of the helix 2 mm at a time. So the design is quite similar to finger spring, but the big difference between the finger spring and the palatal canine retractor is the presence of the guide arm. Okay, this is the guide arm. Okay, beside bows and spring, screws is also one of the active component. The screws are activated by the patient himself or herself at regular interval using a key. Okay, it consists of the split acrylic plate and Adam's clamps at the posterior teeth for retention. The screw is placed connecting the split acrylic plate, and then this appliance can bring about various types of tooth movement based on the location of the split, the location of the screw, and then the number of screws used in the arch, and then the screws is mainly used for arch expansion. Elastic are seldom used along with removable appliances. It's mostly used in conjunction with the fixed appliances. Okay, removable appliances using elastic for anterior retraction generally make use of the label bow with hooks placed distal to the canine. For example, this is the hooks that's placed distal to canine, and then it used in conjunction with the fixed appliances like this. Okay. The latex elastic are stretched between them and lie over the incisors. So the rubber bands or the elastic is being given to patient, and then patient need to change the elastic every 24 hours. Okay, it mostly rely on patient. And then the disadvantages are there is a risk of elastic to slip inside the gingiva, causing the gingival trauma. And then there is the risk of the arch form getting flattened. Okay, for example, look up at this clinical photo. Okay, the fixed appliances is being placed in order to prevent the slippage of the elastic towards the gingiva. However, the elastic will flatten the anterior teeth, okay, because there is no wire supported at the anterior teeth. So that's the disadvantages of the elastic. Okay, now why we use stainless steel wire as a retentive and active component? The stainless steel wire characteristic is good so that it being chosen as the retentive and active component. I'm sure you already have a lecture about this topic. Okay, and then for this topic, you need to know what size of the wire, and then what is the wire gauge for each clasp, bow, spring, and retractor. Okay. And then just have a look at this table, and then this table is from your textbook. Okay, now we move to base plate. Base plate is one of the components in the removable appliances other than active component and retentive component. The bulk of the removable appliances is made of the acrylic base plate. It incorporated all the components, which is the retentive and active components, together in one single unit. It helps in retention of appliances for encourage and distributing the forces over the larger area. And then bite plane is a modification of the base plates, and it can be incorporated into the plate to allow intrusion and extrusion of teeth. Base plate can be either in the maxilla and in the mandible. For the maxillary base plate is usually 1.5 to 2 mm thickness. It covers the entire palate till the distal of the first molar. The full coverage helps in gaining adequate strength. And then narrow maxillary base are less stable and more likely to get dislodged during movement of the tongue. So in this picture, we can see that the base plate incorporated all the retentive component and the active components into one single functional unit. Okay, now how about mandibular base plate? The thickness usually more or less within 1.5 to 2 mm thickness. It's usually shallow to avoid irritation to the lingual sulcus here. To compensate this, it should be made thicker to increase its strength. And then the base plate should fit snugly around the neck of the teeth that are not being moved. This will help in avoiding food accumulation under the base plate. What are the material used in base plate? Usually, we will use either cold cure acrylic or heat cure acrylic, but cold cure acrylic is most commonly used, okay, because it's simple and less time consuming. The disadvantages is more chance of porosity and not as stable as heat cure acrylic. Care should be taken to block out undercuts during construction to ease in insertion and removal of appliances. Bite planes is the modification in the base plate by thickening of the acrylic. It can be either anteriorly or posteriorly, so it helps in disengaging the occlusion. For anterior bite plane, like what you see in this photo, are fabricated by thickening of the base plate behind the maxillary incisors, and this usually done in a treatment of deep bite. So in a treatment of deep bite, we will engage the occlusion in order to allow eruption of the upper and lower molars. Okay, and for the posterior bite plane, as shown in this photo, okay, are formed by extending the base plate to cover the occlusal surface of the teeth. In this case, usually in a treatment of crossbite, where we will expand the arch so that we can treat the crossbite. For the clinical management of removable appliances, what you need to know is how to issue the appliance properly to patient and what instructions should be given to the patient. For the issue or delivery of the appliance to the patient, it should be made within 1 or 2 weeks from the date of taking impression in order to make sure that the appliance will be fitting properly. And then for the instruction, both verbal and printed version of instruction should be given to patient. Instruction should be on the use and care of the appliance. What should you do during delivery of the appliances? First, check the appliances. Run your finger over the appliance to check for any sharp edges and trim if needed. Then, insert the appliance in patient mouth. Base plate may need some trimming of undercut for easy insertion and removal of the appliances. Okay, if you don't trim the undercuts, the removal appliances won't fitting well. And that is examine the clamps for adequate retention. Adjust the clamps for better retention. Okay, it's easier to adjust the Adam clamps. Okay, you just need to bend the arm a little bit so that the arrowhead will insert into the undercut for better retention. And then the active component should rest at the desired location passively. Okay, when you first issue the appliance, make sure you issue passively and then do not activate the active component yet. This should not impinge any soft tissue. And then teach patient on how to insert and remove the appliance properly. Pay attention to the active component not to distort it during insertion. Okay, and then issue appliance passively. Give review appointment after 1 month to check for patient compliances. If compliances is good, then start activating the spring for desired tooth movement. So what to check whether the patient is wearing the appliance or not? First, you can just talk to patient and then you can see how patient, the way patient pronounce some words. So when patient wear the appliance properly, okay, patient can pronounce some word properly, and then you need to see any wear sign on the appliances. Okay, and then once you get you confirm that the patient is wearing the appliances, then only you activate the spring. This is because once you activate the spring, and then it will cause some desired tooth movement, and then patient may feel discomfortable. So if the compliance is good, patient might wear the appliances once we are activated. But if patient does not wear the appliances, and then the prognosis for treatment is very low. Okay, once you patient able to insert and remove the appliances by himself or herself, and then instruct patient to wear the appliances 24 hours full time except during brushing teeth. Okay, even during eating also patient need to wear the appliance. Okay, it is recommended to wear the appliances during meal time. Remind the patient to clean the appliances from food debris after every meal, and then clean the appliance carefully using detergent and soft brush. Beware of bending or dislodgement of any wire component during cleaning, and then clean using room temperature water. Okay, do not put the appliances inside hot water or else it will be damaged. And then give clear instruction on how to turn the screw if there is screw as one of the part of the removal appliances, and then teach the patient to turn the screw properly at home. For example, quarter turn per day for rapid expansion. Okay, and then instruct patient to report immediately to dental clinic if any case of appliance damage or any other problem or emergency while wearing them, and instruct patient not to leave the appliances out of the mouth for a long period of time, as it increases the risk of loss and damage. The longer the wear, the more effective tooth movement. Okay, once you give a proper verbal instruction to patient, this is an example of printed version of instruction that you can give to patient. This is patient information leaflet for removable appliances. I took this sample from the British Orthodontics Society website. Okay, you can have a look. There is a lot of patient information leaflet, not only for removable appliances, it's for functional appliances, fixed appliances, and many more. I will instruct you on how to get the leaflet from the website by the end of this lecture. Okay. This is the continuation of the patient information leaflet. So there have some question and the answer that patient might ask you, and then this is how you should answer them. So you can read this for better understanding. Once you issue the removable appliances, the first question, the most popular question that patient might ask you is, what is the risk of this therapy? Or what is the risk of this treatment? So this is the problem that might encountered during the removable appliances therapy. Okay, it may cause difficulty in the oral hygiene maintenance, and then poor oral hygiene may increase the risk of gingivitis, gingival hyperplasia, and caries. So for removable appliances therapy, you also need to give a proper oral hygiene instruction to patient, and then they need to remove the removable appliances before they brush their teeth, and then put it back after finish brushing their teeth. And then this kind of treatment using removable appliances also may cause soft tissue irritation. Any sharp nodules or edges in the base plate, as well as overextended wire, may cause soft tissue trauma and ulceration. So if ulceration occur, you can make some adjustment to the wire, and then you can also instruct patient to put some bone jailer or any medication to the ulcer. Okay. And then of course it may cause some pain because there is some tooth movement. Patient may feel either discomfort or pain. And then excessive force by active component can cause tenderness and even pain to the teeth being moved. And then patient also may experience some tooth mobility. This is mainly due to excessive force and traumatic occlusion. So now, as a recap, you should ask yourself, are you able to explain the components of removable appliances and their uses? And then, are you able to construct and manipulate removable appliances? So for the next 20 slides after this, I think is the most important slide for you to have a better understanding of this topic. Okay, I hope you can pay attention to the upcoming slide. Okay. Once you are able to understand fully about removable appliances, then only we have a look on the clinical application of the removable appliances. This is a clinical photos of a patient with midline dysteema before treatment, during treatment with removable appliances, and after treatment. In this case, a patient used a splitted label bow to close the gaps between the midline dysteema. So might be within 6 months to 1 year, the midline dysteema was closed successfully. This photo shows a patient with anterior crossbite with mandibular displacement, meaning that when patient try to close his mouth, patient have a premature contact between lower incisor to the upper right central incisor, and then patient will move the mandible forward to gain a maximum intercuspation. So how to treat this case? Can we do removable appliances, and what is the design? Yes, this is a suitable case to be treated with removable appliances. And then this is the design of the removable appliances that we use to this patient. We can see that we use retentive components of Adam's clubs on both upper molars, and then another retentive components which is label bow at the front teeth. At least we need a 3 point of retentive component to get a better stability of the removal appliances. And then how we want to push the upper incisor forward. So we will use a Z spring to push the incisor labially to get the positive object and then to correct the crossbite. And then have a look on the acrylic base plate. So for the acrylic base plate, there is some modification where posterior bite plane is being placed on top of the occlusion of the teeth. So when patient wears the removable appliances, the lower teeth will bite on the posterior bite plane and disengage the occlusion. When the occlusion is disengaged, then only the upper incisor can tip labially without any interference of the lower teeth. And then we can correct the anterior crossbite successfully within 6 months to 1 year with good patient compliance. Now let's have a look on the basic design of removable appliances. Okay, this type of question maybe come out in your OSCE or short answer question where you will be given a study model with constricted upper arch, and then the question is please construct upper removable appliances to expand the upper arch, and then this is how you need to draw, and then this is how you need to explain your drawing. You need to draw properly like what you see in this slide, and then stated midline expansion screw, Adam's clasp on both upper right and upper left first molar, and then stated the size of the wire as well. And then you also need to explain, you also need to write the Adam's clasp on the deciduous teeth, and then the size of the wire used, and then also stated half occlusal coverage posterior capping. Posterior capping is another name that we use for posterior bite plate to disengage the occlusion. And then you also need to explain about the midline split in base plate as indicated to put the midline expansion screw. And then you also need to write up the base plate saddle as indicated. This is another potential exam question. Please construct a URA to distalize or to retract the upper lateral incisor and the upper left central incisor to reopen space for upper right central incisor. So in this case, upper right central incisors is impacted or maybe delayed in eruption. So we need to gain some space to allow the normal eruption of the upper right central incisor. So the design as follows. You need to draw the design like this on the lab card or in the exam paper, and then you need to state the location of the springs, the active component, the retentive component, and the base plate. Okay, this is the cases with buccally erupted canine. Let's say you are given a study model with this kind of malocclusion, and then the question is, please construct a URA to retract the buccally erupted upper canine teeth. So you need to draw like what you see here. You need to state the location of the active component, on which teeth, and then what wire do you use. So in this case, buccal canine retractor is used, and then this is a supported buccal canine retractor where metal sleeve or metal tubing is being used. So you need to state the wire gauge, which is 0.5 mm hard stainless steel wire with the metal tubing, and then you need to state what is the diameter of the sleeve as well. And then you also need to state the retentive component, which is the Adam's clasp on the first molar, and then the south end clasp on the incisor. And then don't forget to write up the size of the wire as well. And then don't forget to write the base plate as well. Okay. Now you need to construct a URA to distalize the upper left 6. So in this design, I want to highlight on the screws and the posterior capping or the posterior bite plane. So you can see there is extra lines are being drawn on the design. This shows the acrylic base plate is being modified to be a posterior bite plane to disengage the occlusion. So in order to write it up is you need to say only half of the occlusal coverage posterior capping or posterior bite plane, so that it won't covers until the bridge of the Adam's clubs. Okay, and then you also need to state that orthodontic screw is positioned as shown. Okay, and then you also need to draw it properly so that the technician can do the removable appliances as shown here. This is another example on how to construct a URA to expand the upper arch. So we can see that the expansion screw is being placed like this, and then more expansion is needed on the quadrant 2 to move the palatal and the molar buccally. So I want to highlight on the expansion screw and the posterior capping as well. So you need to draw properly and write properly. Don't forget to write the active component and the retentive component properly, on which teeth and what wire should you use. Okay, this is an extra notes on how to draw the design of twin block functional appliances. In this case, they use a labial bow on the upper part of the twin block. So if we use upper bow and then there is a expansion screw, once the screw is being activated, and then the labial bow will become tight. So sometimes orthodontists will use ball-ended clubs to replace the labial bow. So otherwise, this is the design, and then we can see that the bite blocks are being drawn like this. Okay, and then don't forget to write the components properly, at which teeth, and then the size of the wire. Okay, now let's have a look on some factual recall question. Name the active component of the appliance. Is screw. What is the action of the appliance? The action is for arch expansion. Okay, let's have a look on the yellow arrow. The yellow arrow shows the direction of the key used to turn the screw. This is the key used to turn the screw. So we can see there is a blue arrow in this appliance. And then the key should be given during issue, and a good instruction on turning the screw for arch expansion is given to patient. Name the modification of the acrylic base plate. This is upper removable appliance with flat anterior bite plate. What is the action of this modification? Flat anterior bite plane is used to disengage the occlusion. Therefore, it can allow the lower molar to erupt, and it will allow some intrusion of the lower incisor. What condition does it treat? It treats deep bite and increased curve of speed of the lower arch. Name the modification of the acrylic base plate. This is upper removable appliance with inclined anterior bite plane. What is the action of this modification? It used to disengage the occlusion and also to maintain the correction of the class 2 division 1 after treatment with twin block functional appliance. What condition does it treat? It will treat deep bite in a class 2 div 1 malocclusion. Name the modification of the acrylic base plate. This is upper removable appliance with posterior bite plane. What is the action of this modification and why? Posterior bite plane is used to disengage the occlusion, so that in this case we have Z spring behind the upper lateral incisor. The upper lateral incisor is displaced palatally. So in this case, posterior bite plane will disengage the occlusion so that the upper lateral incisor can be proclined successfully without any interference of the lower incisor. What is the appliance used for? This appliance is used to tip the incisor labially or to push the incisor labially. Name the components of the device and on which teeth. In this appliance, we have active components, which is the Z spring, placed behind the upper incisor. And then we also have a retentive component, which is the Adam clamps placed on the incisor and then premolar and molars. And then we also have the base plate, which is modified into a posterior bite plane to disengage the occlusion. And this base plate covering all the components and hold all the components together. Give the wire gauge. For the Adams clamps, we use 0.7 mm stainless steel, and then for the Z spring, we use 0.5 mm stainless steel. What is the appliance used for? This appliance is used to push the incisor labially. Name the components of the device and on which teeth. Okay, on this upper remover appliance, we have retentive component, which is the Adams clamps on both first molar, and then we also have label bow covering from canine to canine. And then we also have a Z spring as an active component to push the incisor labially. And then apart from that, we also have base plate that holds all the components together. Give the wire gauge. The wire gauge is 0.7 mm for Adams clamps and label bow, and then 0.5 mm for Z spring. What is the appliance used for? This appliance is used to move the upper canine distally. Name the components of the device and on which teeth. Okay, for this appliance, we have retentive component, which is Adam clamps on the both first molar, and then we also have south end clamps on both upper central incisor. And then we also have active component, which is the finger spring on both canine. Finger spring is also known as single cantilever spring. Give the wire gauge. For the Adam clamps, we use 0.7 mm stainless steel. And then for the south end clamps, we also use 0.7 mm stainless steel. And then for the finger spring, we use 0.5 mm or 0.6 mm stainless steel wire. Name the active and retentive components and on which teeth. The active component is Z spring and is located behind the incisor. And then the retentive components are Adams clamps placed on the premolars and molars. Give the wire gauge. The wire gauge for Adam clamps is 0.7 mm stainless steel, and then for the active components, the Z spring, the wire gauge is 0.5 stainless steel. Name the two clamps and the wire gauge. The two clamps are Adams clamps on the first molars and the modified label bow on the upper central incisors. Name the two springs and their wire gauge. The two springs are, the first one on the quadrant 1 is the buccal canine retractor. We can see there is a metal tubing on the distal arm, so this will be a supported buccal canine retractor that use 0.5 mm stainless steel wire. Whereas for the quadrant 2, we can only see on the label part, so we cannot see the design on the palatal part. So this can be finger spring or palatal canine retractor. So the difference in the design in these two types of components is the finger spring, they only have helix on the palatal side, but for the palatal canine retractor, there will be a guided wire. So if this is a finger spring, then it will use 0.5 mm wire gauge, and then if this is a palatal canine retractor, it will use 0.6 mm stainless steel wire. Name the active and retentive components and on which teeth. So in this appliance, we can see a palatal canine retractor. So this is the guided wire. Okay, this is the guided wire. So they put the palatal canine retractor is on both canine, on quadrant 1 and quadrant 2. And then for the retentive component is the Adam clamps on both first molar. And I think there is also a ball-ended clamps on the mesial of premolar. And then there is also south end clamps on the upper incisor. Okay, and then give the wire gauge. Okay, for the Adams clamps, the wire gauge will be 0.7 mm stainless steel, and then for the south end clamps will be 0.7 mm stainless steel as well. And then for the palatal canine retractor, it will be 0.6 mm stainless steel wire. Name the spring and what it is used for. This is a self-supported buccal canine retractor, and then it is used to move the canine in distal and palatal direction. What is its gauge? Because this is self-supported buccal canine retractor, It is made of 0.7 mm stainless steel. Name the active component and what it is used for. The active components is T-spring and it is used to push the premolar buccally. What is its gauge? The gauge is 0.5 mm stainless steel or 24 gauge wire. Name the spring. This is activated label bow. What is the gauge of the wire? For activated label bow, we use 0.7 mm stainless steel or 22 gauge wire. What condition does it treat? In this case, we will do anterior retraction in a class 2 division 1 malocclusion. Name the spring and type. So in this picture, we can see there is two springs. The first one is the robot retractor, and then the second one is either finger spring or palatal canine retractor. The type is the active components of the appliance. What is the gauge of the wire? For the robot retractor, we can see it consists of metal tubing at the distal arm. So it uses 0.5 mm stainless steel wire. And then for the finger spring or the palatal canine retractor, it uses 0.6 mm stainless steel wire. What condition does it treat? Okay, for this case, robot retractor is used to retract the anterior teeth palatally in the cases with increased overjet. And then for the finger spring or palatal canine retractor is to move the canine distally. Name the appliance. This is the upper Hawley retainer. What it is used for? Upper Hawley retainer is used to retain the occlusion after removal of fixed appliance. Enumerate the component. So in this Hawley retainer, Hawley appliance, we can see they use Adam's clamps on both first molar and label bow from canine to canine, and then both components is attached together by acrylic base plate. So this is a passive appliance. So the label bow and the Adam's clamps is used as a retentive components. What is appliance A used for? Appliance A is a Hawley appliance or Hawley retainer. Is used to retain the occlusion after removal of fixed appliance. What is appliance B used for? Appliance B is used for anterior retraction in cases with increased overjet or spacing of the upper labial teeth. And the difference between appliance A and B is, in appliance B, there is some relief of the acrylic base plate behind the upper incisor. This is because this appliance is used actively to tip the upper incisor teeth palatally. So that's why there is the acrylic covering at the palatal is trimmed a bit. So whereas in appliance A, there is a good adaptation of the acrylic base plate behind the upper incisor so that the labial bow can retain the position of the upper incisors after removal of the fixed appliance. So we call appliance A as an passive appliance to retain the occlusion, whereas appliance B is an active appliance to move the upper incisor teeth palatally. Name the appliance. So this is what we call vacuum form retainer. What it is used for? Vacuum form retainer is used to retain the occlusion after removal of fixed appliance. Okay, now we are approaching the end of the lecture. Besides textbook, you need to read your textbook. Okay, so besides textbook, you can also read some other books such as the Orthodontic Retainers and Removable Appliance or Introduction to Orthodontics by Laura Mitchell. I'm sure they have this in your library. Okay, besides that, you can also Google search British Orthodontic Society website. In this website, they have a lot of patient information leaflet, including removable appliance. So that you can have better understanding about this topic. Once you enter this website, you can click to BOS homepage and then choose patient information leaflet, and then click on the removal appliances, and then you can download the removable appliances leaflet here. Besides that, you can also Google search for website of the private laboratory, where you can explore many more design of the removal appliance. If you need more help with this topic, you can email me at rafidah@pidc.edu.my, or meet me personally at level 21 PIDC on Friday morning. So this wrap up my lecture for today. Thank you for your attention and stay safe. Bye-bye. Assalamualaikum.